Hello everyone, now I'll discuss question of pediatric. So we have a 2-day-old girl, seizures and bulging anterior fontanelle. Temperature is by and large slightly on the lower side. Capillary refill of more than 4 seconds. She has rhythmic contraction of upper extremities, tongue thrusting and lip smacking. Blood sugar is in the normal range. Hemoglobin is very low. Well, a packed RBC transfusion is done. Phenobarbital is given intravenous, seizure actively restored. Cranial ultrasound is performed and that reveals bilateral hemorrhage involving the germinal center, lateral ventricle and surrounding brain parenchyma. Which condition? This happened due to which condition? Okay. Well, the answer is this all occurred due to prematurity. Well, there is a bleeding in the brain. So let's learn something basic concept about intraventricular hemorrhage before I really discuss this question. The pathophysiological features are ruptured germinal matrix vessel, prematurity and very low birth weight. The clinical feature often asymptomatic, seizure like in our case, full fontanelle like in our case, in the patient of the question. An acute anemia, yes, our patient has a hemoglobin, very low hemoglobin. We diagnose by cranial ultrasonography we use. Okay, it's a 2-day-old child. Now, how we really do the grading of intraventricular hemorrhage? Grade 1 hemorrhage just limited to germinal matrix. Grade 2 intraventricular hemorrhage, 50% of the ventricle or ventricles dilatation. Grade 3, more than 50% of the ventricle dilated. Even there is a hemorrhage into parenchyma also. That is grade 4. Now, in our patient has grade 4 intraventricular hemorrhage due to ruptured germinal matrix vessel. Hemorrhage can be limited to germinal matrix or entire lateral ventricle. And ventricle dilatation may occlude draining of vein and lead to surrounding parenchymal bleeding. This how actually grade 4 hemorrhage occurs because of draining veins, they get occluded and they can cause secondary parenchymal bleeding, and parenchymal bleeding is a criteria of grade 4 as we have seen in the previous slide also. Parenchymal hemorrhage is grade 4. Now, primary risk of intraventricular hemorrhage is prematurity. As preterms, they are very fragile vasculature and they are more susceptible to acute changes in the cerebral perfusion also. So that can lead to hypotension, swinging in oxygenation and increased venous pressure. Why? Because it's a venous drainage which is hampered, which secondarily causes parenchymal bleeding also. Well, intraventricular hemorrhage typically occurs within 7 to 10 days of birth. In our case, it was just 2 days old child. Okay. It can present with anemia and tachycardia due to hemorrhage. Like in our case, pulse is 180 and anemia 9 g% is there. Apnea, seizure is there in our case. Focal deficit and bulging fontanelle was there in our patient. However, majority of them are asymptomatic. Therefore, preterm infant should have a regular screening ultrasound. Why? Because a patient may have no symptom at the moment, but later on, patient can have a problem in neurodevelopment. There can be cerebral palsy or intellectual disability. So it's very, very important to rule out any of the bleeding in the brain. Well, let's look into other options. AV malformation may cause left to right shunting within the brain. It results in ischemic changes in the brain parenchyma bypassing the malformation. Hemorrhage is usually not seen in the brain AV malformation in newborn. Option B, macrosomia, is associated with traumatic or device-assisted delivery like forceps and vacuum. It can lead to intraparenchymal or subdural hemorrhage. Hemorrhage associated with delivery are usually small. Usually they do not require any intervention and they are usually not intraventricular. If you can see, they are merely intraparenchymal or subdural type of, but it's usually minimal, not very massive. Placental abruption may be associated with hypoxic ischemic injury to fetal brain. It can lead to diffuse neuronal injury. Abruption is less commonly associated with IVH. Well, prenatal infection, very, very important point. Some of the pre-infection can be cause injury to the fetal brain. Cytomegalovirus, Zika virus, they may destroy neuronal progenitor, leading to microcephaly. Cannot afford to forget this line. Very, very important line. Herpes simplex, varicella zoster can lead to diffuse neuronal disruption. And now I have a question. Which prenatal infection can lead to hydrocephalus? Stop the video, write down the answer in your copy. Toxoplasmosis can lead to hydrocephalus because they can obstruct ventricular outflow of CS. But definitely they are usually not associated with IVH. Golden line to remember. Primary risk factor for intraventricular hemorrhage is prematurity. Affect neonate may have sign of acute blood loss, anemia, tachycardia. Neurological injury, seizure, bulging fontanelle, sometimes apnea can be there. Many infants are asymptomatic and risk infants should receive screening with cranial ultrasound because in due course of time, if the bleeding is there, it can lead to cerebral palsy or delay or some problem in psychomotor development also. Okay. Thank you very much.